and welcome to the MDR-TB NITRD Echo Clinic. And I am so happy to welcome all our district TB teams from Delhi. In addition to whom we have the STO office from Sikkim. I think they are joining for the first time. Welcome STO office Sikkim. And we have the STO Tamil Nadu. We have people joining us from Guwahati. And we have people from CTO Mumbai. And a big welcome and thank you to the team from NIMHANS Bangalore. They are the apex institute in the country for psychiatric and neurosciences, and they're to assist us today and also to deliver the didactic which all pertains to psychiatric disorders. Today's clinic is on psychiatric disorders. And now I would like to introduce you the team that I have. On my left, I have Dr. Munjal. He will be our chest physician expert for today. Dr. Munjal is a senior chest physician and unit in charge of the clinical unit 1 in NITRD. On my left, I have Dr. Manpreet Bhalla. She is a senior microbiologist and has done immense work in microbiology over the past 20 years in NITRD. The main experts today are the NIMHANS team. I would like to welcome Dr. Prabhat.
Myself, Prabhat, additional professor of psychiatry, and I run the whole ECHO program here.
I am Santosh Chaturvedi. I am a professor of psychiatry and dean of behavioral science.
Yeah, myself, Dr. Roshan. I have finished my doctoral fellowship in consultation liaison psychiatry, and I will be talking as the expert panelist regarding the issues related how to handle the psychiatric side effects of some of the drugs which are used.
So with this few introductory remarks, I would like to invite Dr. Roshan from NIMHANS to deliver his didactic, which is on psychiatric ADRs in management of tuberculosis or of anti-tubercular drugs. I think everybody here would agree that psychiatric side effects or psychiatric symptoms, psychiatric problems that we see in our patients of TB are really challenging. There are two reasons for the challenge. First reason is none of the chest physicians or TB people are trained in psychiatry. So we are actually totally at sea when we see somebody behaving in a different manner than normally acceptable behavior. And secondly, patients of TB and especially MDR-TB are already so sick. And these are usually people who already have huge adherence issues. And to add to all this, they develop psychiatric problems, which make the problem of adherence and continuing treatment even more. And over to Dr. Roshan.
Okay. For inviting me as expert panel, first of all. In 1 or 2 minutes, if I have to summarize what is psychiatry. Liaison psychiatry is, where the behavioral or the psychiatric issues associated with the patient admitted in general hospital are attended expert psychiatrists who is aware about how to handle their concerns in a slightly different way rather than the conventional psychiatric practice. Is called as a liaison psychiatrist, and the practice which involves the liaisoning. We know that regimens used for the tuberculosis, specifically MDR-TB, has been reported to cause more adverse effect and than the first line agents, and contributing to the discontinuation rates up to 55%. These are the major culprit drug which amounts for the behavioral disturbances. The significant the drugs for which we have the evidence which is very strong enough are INH and Cycloserine, and it's very well established that these drugs cause multiple behavioral disturbances starting from sleep to the delirium. Psychiatric. So let's come back to the final slide. Take home message: the psychiatric comorbidities are not a contraindication to tuberculosis and MDR-TB therapy. Possible extended inpatient care would be helpful to keep patients in treatment. Along with the active liaison psychiatrist supervision, management of psychiatric complication is possible without compromising the anti-tuberculosis treatment.
Thank you so much for being with us and telling us. And I'll now open the discussion to the house. Would anybody like to ask any question on the presentation? Dr. Roshan would be happy to take the questions. Yes, NIRT Chennai, please ask your question.
I have one doubt. Do we have to continue treatment for a period of 3 months or 6 months? Those antipsychotics?
Hi, okay. So Dr. Roshan, the question is that once you have started the antipsychotics, do you need to continue it for 3 months?
Yeah, thank you for asking that question. I think we have to decide somewhere that what is the psychotic disturbance happening with the patient. So just like I mentioned, the mild to moderate and severe. So when you consider that the psychosis is self-limiting and mild to moderate, is not interfering with the treatment or the other aspects of the compliance related to the treatment, I think you should treat it as short as possible till the psychotic symptoms resolve. It may be a 1 week or 2 week. If it is severe enough, I think it's a good idea to continue it as long as the intensive phase of anti-tubercular regimen is there, and then assess the patient once again about psychotic symptoms and taper and stop or continue based on that assessment.
So what I do is usually I give them for 2 weeks and then you wait, and then with the good psychotherapy and the family therapy as well, and then I taper off the drugs. I don't keep, especially with risperidone and all, like start with 2 milligrams and go to 1 and then stop it. And most of the patients do not have much of a problem. So it's only the initial phase, either it is for ATT or for ART. I didn't have a patient who had to continue beyond 1 month.
NIMHANS team, can I ask you a question? Doesn't it take about 2 weeks for the blood levels to be at a therapeutic level? Like, wouldn't 2 weeks be actually too early to stop? I am a bit confused about this.
No, it doesn't work like that. In practice, what you're saying about having effect in 2 weeks and 4 weeks, it is in drug trials. In actual practice, the day you give antipsychotic, it starts correcting the symptoms. It does not be an adequate blood level for an antipsychotic or an antidepressant effect. If you give, let's say, a low dose of risperidone or olanzapine, immediately it has effect on sleep. So these effects are there immediately. So sometimes the organic psychosis has the hallucinations and delusions. These also respond very fast in that. It is only in functional psychosis where we expect that it might take a few days to have full effect. But otherwise, in practice, actually the effect starts immediately.
Thank you. Okay, Dr. Neetu, please begin your case presentation.
Hello to everyone. I am Dr. Neetu Singh, District TVA Officer, Chase Clinic, Malviya Nagar, South Delhi. I will be presenting a case of young female MDR-TB patient with psychosis. The patient is 30-year-old female with history of exposure to tuberculosis. Her mother was a case of pulmonary tuberculosis. Presented to ENT OPD AIMS with complaint of swelling of right side of neck for 20 days and dry cough for 15 days. On examination, there was tender lymphadenopathy, right side upper jugular region. An ultrasound neck was done, which shows 3.3 and 2 centimeter swelling behind right side parotid, feature suggestive of infective evolving abscess. FNAC of lymph node was done and pus aspirate was sent for CBNAT, which shows MTB positive and resistant to rifampicin. Blood sugar was normal and HIV were negative. Chest X-ray was normal. This is the chest X-ray, which was normal. Patient developed abnormal behavior, loss of sleep, negative thought, including suicidal thought and hallucination after a week of treatment. Senior DRTB doctor then stopped cycloserine and started fast around 25th March 2017. Even after stopping cycloserine, there is only partial relief. First is, what is the cause of psychosis? Second, and how to manage the case further.
Thank you, Dr. Neetu. That was an excellent case, and I would just summarize it in 2 lines. A girl who is 30-year-old, she has MDR-TB. It's an extrapulmonary MDR-TB of a right cervical lymph node, which is gene expert positive and shows MTB. The patient was given category 4 ATT, after which included kanamycin, cycloserine, ethionamide. When the patient developed psychiatric symptoms, loss of sleep and hallucinations, including suicidal thoughts. Some psychiatrist in one of the primary health centers advised alprazolam initially. The patient did not respond to that, but there is no past history of psychiatric illness as informed by the patient. So this is the case, and the issue here is how to manage a patient who develops psychosis when you give anti-tubercular therapy, and when the expected drug which would have caused it is also stopped, and the person persists to have psychiatric symptoms. So how are we to manage these cases? So if we have any comments or suggestions from the house, I would like to take them now before we go to our experts from NIMHANS. So there are no questions from the house, and I would now like to request our NIMHANS team to please give their expert comments on this case.
First of all, I would like to start with some clarification of psychiatric symptoms that patient has exhibited. These symptoms, suicidal things and sleep disturbances, and there are some issues related to the divorce that person is thinking of. I am very unclear about the symptom profile of patient at first instance, that whether it's anxiety, whether it's depression, or whether it's psychosis or it's delirium.
डॉक्टर नीतू, ये बोल सकते हो कि उस जो आपने देखा तो क्या बोल रहा था वो आपको कि मेरा डाइवोर्स हो जाएगा, उसके अलावा और क्या बोल रहा था वो?
Within 3 to 4 hours नेगेटिव थॉट आते हैं, कोई परछाई आ रही है, सुसाइडल थॉट होते हैं कि मेरा डिवोर्स हो जाएगा, कुछ खाली परछाई आ रही है, कुछ आवाजें सुनाई दे रही है, मतलब एबनॉर्मल साउंड आ रहे हैं।
मैं आपसे ये पूछना चाहूंगा, उनकी शादी में कोई और पहले से अनरिलेटेड टू दिस थिंग कोई पहले से कोई प्रॉब्लम थी?
नहीं, डिफिकल्टी नहीं है, बट दे हैव नो, मतलब बच्चे तो नहीं है।
बच्चे नहीं है ना, एक तो ये बात हुई। अच्छा, दूसरा ये है कि उनमें उनके हस्बैंड की फैमिली में कोई स्टिग्मा है कि इसको टीबी है, कहीं हम लोगों को भी टीबी ना हो जाए?
इसके हस्बैंड से भी मैंने बात की थी, लेकिन वो काफी कोऑपरेटिव है, उसके साथ हर बार दवाई लेने आता है, मेडिसिन लेने आता है हर दिन।
Okay, so the most of the symptoms again are a little unclear. The parchai jaisa dikhna can be, a symptom of extreme anxiety or happening repeatedly. Person is, having some visual hallucination like symptom, then it falls into some other spectrum. Hallucinations hai ki nahi hai? Agar patient कहता है कि she can hear some voices, she will also tell it to us. What are these voices telling to her? Are the voices telling her to do suicide, or she is just anxious that I just cannot cope up with all this thing about my family, about my illness, about not having a child, and that is why I want to end of my life. So there are different cognitions associated with this particular theme of case. I would say that why we have assumed that the cycloserine is the culprit drug for this patient. He is on 3 medications which are known to cause the neuropsychiatric manifestations, which include the high dose of levofloxacin 1000 mg, Cycloserine 750 mg, and Ethambutol or Ethionamide, something that is 750 mg. So all 3 drugs have been implicated in behavioral disturbances of patients taking on ATD. So we need not stop something suddenly just thinking because that is because of a cycloserine. So I think that there is one catch. We have to evaluate which drug has caused which symptom. Why don't we follow challenge, re-challenge and de-challenge protocol? If cycloserine was a culprit, introduction of cycloserine again in the regimen would again exacerbate the symptom. Okay, that is number 2. Best thing is to start on the symptomatic treatment. It's exactly same as a patient is having fever. We give him paracetamol for a few days, and then fever subsides and patient any issues. So if it is a drug related, patient should be given on appropriate medication. Either it can be antidepressant if the person fulfills the criteria for depression. It can be antipsychotic if a person fulfills the psychosis. You can still go down on cycloserine from 750 to 600 to 500. You can go down on fluoroquionolone regimen if you don't have any regimen. The catch that you cannot go down on the dose of the medication, but you start at least some medication based on diagnosis of this patient. Diagnosis, psychiatric diagnosis is not very clear in this case. Past history, family history, and the circumstances in which the patient is experiencing symptom can be very brief lasting. The third and very important aspect is that it is likely that patient was not educated about the neuropsychiatric manifestations of fluoroquinolones and ethionamide. If these side effects have been addressed just before starting the medication, I think 50% of work is done.
You asked was what is the cause of psychosis in this. Here, see, the first cause, that is what I was asking, is a psychological reaction to the disease.
Manifestations of shock can be depressive, psychotic, anxious. First of all, we need a proper therapy session with her. Just need to address her concern and then to go ahead with whatever regimen that you want to give as part of ATD.
Thank you very much. This was an excellent handling and expert evaluation of the case. I want to ask the house again if there are any burning quick questions. We would love to take it from the house. So there is one question from NTI Bangalore. Yes, Dr. Chadha, please.
All right, quickly my question is to the NIMHANS team that now the new guidelines prescribe cycloserine in, of course it was already there, and also INH. So do you see this regimen, the combination of INH and cycloserine leading to the additive effect as well as the severity of the symptoms is concerned?
So Dr. Chadha's question is, sir, that the new guidelines are giving cycloserine and high dose INH maybe together. What do you expect would be the additive effect of having 2 such drugs in the regimen? And there would most likely be fluoroquinolone also, maybe not, ethionamide, maybe not. So what do you feel would be the effect of this new guideline on treatment of drug-resistant TB cases?
It might be good for the tuberculosis, but one has to be aware that the risk for psychiatric morbidity increases. There are simple questions, and just be aware that person is disoriented or person is becoming little confused or becoming very emotionally labile, suddenly staffing, crying. Time goes by, we will come to know what is the prevalence of psychiatric problem with this combination. But I'm quite sure it probably has a good prognosis for the disease, so people might be more reassured. But the clinicians should be more cautious about any psychiatric complication which might arise.
Adding on that to further as a last, the new guidelines we were not aware of, but if it mentions INH plus cycloserine, the efficacy will increase at the same time. Side effects are likely to increase, and they are adding up each other. So why not to combine INH and cycloserine with risperidone at the same time is another question for the future.
Thank you very much. That's a very good thought, Dr. Roshan. And I'm going to now give the mic to Dr. Sushil Munjal, who is our TB and RD expert and has got huge experience in treating MDR-TB cases. So I want to hear from him on this issue.
The most of things has already been covered by the NIMHANS team. But I want to just ask them one question. If the patient go for suicidal ideation and if he needs admission, which will be a better place, a TB ward or a psychiatric ward?
So obviously, suicide is a high-risk thing.
Yeah.
And what is required is keeping an eye on the person. You have to make an eye-to-eye supervision all the time. If it is because of depression which requires treatment and the suicide is because of depression, might require ECT or any other acute intervention, then it should come to a psychiatric hospital.
This message should be very clear to all chest physicians that if the patient has a suicidal ideation, then patient need a psychiatrist's help, and preferably he should be admitted in a psychiatric ward, because this is sometimes the counseling doesn't work even in a suicidal ideation. My second question is, in this particular case, it was not cycloserine induced. And if you go by the guidelines, we as a physician always go by the guidelines. Our guidelines are very clear that if patient develops a psychiatric illness, one need to stop cycloserine, which was again not told by Dr. Roshan. Dr. Roshan was very clear that there is no need to stop the treatment. So this is a little bit confusion. I want to clear it out that if we have to follow the guidelines, and they says you have to stop the medicine for 1 to 4 weeks and start with the antipsychotic. If the patient improve, fine, reintroduce the medicine. If needed, can go in the lower dose. This is our guidelines.
So Dr. Roshan, the issue here is, do we continue cycloserine or other potentially psychotic drugs under the cover of antidepressant / antipsychotic / psychiatric evaluation, or do we stop, first stabilize the patient and then re-challenge?
There's a clear difference in the guidelines and the practice, the clinic, that I would like to highlight. There are 3 things that are possible with your question. So one is that whether the dose reduction is possible with the cycloserine. You have to categorize the patient, the mild to moderate psychosis versus psychosis, which disrupts the treatment, so that you can continue low dose of cycloserine along with the antipsychotic. Third thing is that if the cycloserine antipsychotic low dose combination is failed, the patient's mental state back to what we call as a normal, then you stop the cycloserine. There is a very good guideline which says that you stop cycloserine. You treat it for 1 month with the only antipsychotic regimen and probably other ATT regimen. You see the psychotic symptoms are not there, you re-challenge with the cycloserine low dose. Start maybe with the 250, then 500, then 750, and then up to 1000 if required. And then you see whether symptoms reappear, and then adjust the antipsychotic.
The other recommendation is, they say start with the pyridoxine 300 milligram. What's your reaction?
I personally am not expert in tuberculosis treatment using the pyridoxine, but I have across the literature states that 100 to 200 milligram of pyridoxine can be used prophylactic.
So the take-home message for today's talk is that we need to be aware about drugs which can cause psychiatric symptoms, prior psychiatric illnesses which might be getting overt or unmasked now and contributing to the problem of psychiatric disorders that we see during treatment of drug-resistant tuberculosis. Be aware that patients who are on second-line drugs can have psychiatric symptoms to drugs, as well as unmasking of already undergoing psychological issues in their lives. Third, it could be the stigma itself. Then once you have detected a person to have a psychiatric symptom, please refer early to the nearest psychiatric hospital with a complete case history and what are the doses of the drugs that he is taking. And please get an early psychiatric referral so that a trained psychiatrist can assess what kind of problem he has and what kind of treatment is to be given. Once you have that psychiatric referral, please monitor your patient, whether the patient is following the advice of the psychiatrist, how he is doing, is he improving. Please do not take the psychiatric problems in DR-TB cases lightly. We do get 1 or 2 episodes of suicides in our hospital every year for patients who take DR-TB treatment from us. And with this, I would like to give a big hand to the NIMHANS team. Thank you very much. And with this, we will sign off. Goodbye, good afternoon, have a great time.